Babies with fevers.
Mm-hmm.
Yeah, let's talk about babies with fevers. What's going on? Why is this a concern?
This is a big concern. So first of all, newborns. So really new babies don't really have the ability to spike fevers. They don't have the thermoregulatory control to spike a fever. As they get a little bit older, that develops. Babies, all babies, and the premature baby more than the term baby, is to some degree immunosuppressed as compared to the child and the adult.
Fair.
And babies don't have a lot of good ways to tell you they don't feel well. So your little kids will whine and point to things and cry and tell you they don't feel good.
Subtle thing there.
Sometimes your babies just don't have ways to tell you they don't feel well. So think about things babies do when they're sick. So they don't eat well. They'll cry more sometimes. They'll be sleepier than usual sometimes. They may have less urine output because they're eating less. But aside from these subtle things, and sometimes they're less subtle, the baby who's difficult to arouse isn't particularly subtle.
We have a point here about that. But, yeah.
But oftentimes it can be subtle. So when a baby spikes a fever, it's a big sign to us that something is going on. And what we worry about, and it's not always, but what we worry about is serious bacterial infections. Okay. So we worry about bacteremia or sepsis. We worry about meningitis. And in babies, we also worry about urinary tract infections. Babies can also get pneumonias, not infrequently. Now, can your newborn get a viral infection that causes them to spike a fever? Sure. But it's really hard to hang your hat on the fact that you have a viral infection causing you to spike a fever. You can get bacterial superinfections with viral infections. And even when you have some history, like, this baby's 3-year-old brother goes to daycare and came home with a runny nose, and now the baby has a runny nose and a fever. If you're dealing with a baby that's less than 2 months old, that's one that you're going to want to work up.
Got it.
And so when baby is certainly less than 6 weeks, but a lot of the time, the cutoff previously was 2 months for the LP. I'm not positive, but I believe it may have gone down to 6 weeks. But all babies who came to us with fevers less than 2 months would get blood cultures, urine cultures, and CSF cultures. Yeah. And they'd be treated with empiric antibiotics until proven otherwise. Now, would we test them for viral infections? Sure. So let's say that I tested them for a viral infection and I got RSV, but I still have a febrile baby who looks bad. I'm still going to do blood, urine, CSF, and treat him with empiric antibiotics.
So certainly in that first couple of months, this is definitely something on the EMS side of things. Mm-hmm. Parents are like, no, we'll be okay. We'll give the kids some whatever, and this is something we really should be pushing hard for evaluation.
This is something we should be pushing hard to bring into the ED. Yeah. These are babies who universally get admitted from the ED. Correct?
That's a fair, Mm-hmm. Okay. I mean, that audience should know that. That's almost,
if they're less than 60 days and I say I've got a baby with a fever, they're getting admitted just for observation.
Mm-hmm. Yeah. And antibiotics.
Mm-hmm. And it's an early call. I'm an adult emergency medicine physician. We do have PEM specialists, but I treat kids. It's within my scope, but I still feel more comfortable that I'm going to start my initial workup, and I'm going to be calling if it's if they were on your service before, if they were preemie and on your service, or if they're not and they're an older kid, I'm still calling you guys or the PICU to say this is what I have, and I'm going to have you guys guide my antibiotic choice.
Yeah,
because you guys know more than I do,
right?
It's
not your wheelhouse, right?
Yeah.
And calling us is never wrong. And if we're not going to be the ones to admit the baby, or not going to be the ones to see the baby, we can be on the phone with you and the PICU, and we can work together on where the best places to admit this baby and what the best antibiotic choices are for this baby.
And you guys are going to be guiding whether you want that lumbar puncture and if I'm going to do it in the ER. Mm-hmm. And typically, we're doing the lumbar puncture as antibiotics are going up in hopes that we get the lumbar puncture beforehand.
But if you don't, you don't.
Exactly. And that's why we do it simultaneously. And if I get it, I get it. If I don't, I don't.
Yeah. So we would love for you to be able to get all your cultures before we give antibiotics. And we try to get all of our cultures before we give antibiotics. But we live in the real world, and you always want to treat the patient.
Correct. Urine and blood are easy to get to because I need to get access anyways to give those antibiotics. Sure. I can cath a baby, much to parents' chagrin. I would have no problem having someone cath my child. Lumbar punctures, if it's a little bit harder. We don't typically deal on the size of babies that you guys deal with in doing lumbar punctures. I'm used to big, large spaces in between mine.
Yeah.
And not little...
Little thumb spaces.
Yeah, exactly. So. But most of the time, your babies are much thinner than my patients are.
That's probably true.
So.
But your patients can sit up and cooperate.
Yeah, I still do mine.
That might not be a win.
They can sit up.
They can sit up, yeah.
One thing to keep in mind, though, when you're talking about the antibiotics and the CSF, at least at Rainbow, and I think in many places around the country, our ID now has the ability to run something called a biofire.
Yes.
Which is
pretty common.
It's PCR, so it's not a culture.
Correct.
And they'll PCR the CSF for all of the common organisms that can be meningitis. So even if we've cleared the culture with antibiotics, we still have the ability within a few days to get a meaningful sample.
Yeah. Oh, nice.
So always treat the patient. If your neonatal patient looks bad, antibiotics are always one of the answers.
I think that's a big takeaway for EMS too. Again, it's doorway assessment. Is the patient sick or not sick? Are they acting normal or not? And a baby that's not acting normal might not present sick the way we would think, so we need to evaluate it further.
I would go a little further. That let's say that even your doorway says it looks fine, because we're talking neonates, we're talking a month-old, whatever, in mom's arms seems fine, but I would listen to mom or dad say,
absolutely,
no, my child's not acting right.
This is different.
Has not been acting for how long? Because if it's been a day, well, you now have a shorter time to intervene, because we're already a day behind as opposed to 6 hours.
Yeah, we have such
12 hours.
small interaction with those little kids too that it's like, take their advice.
Yeah.
I mean, take their advice.
Yeah.
I mean, I'll tell you right now, my wife knows our daughters better than I ever will when it comes to that, because she's with them all day. And if she says something wrong, something's wrong. And for EMS, we have to listen.
My wife can look at her kids and say they have a fever,
Yeah,
so
yeah.
it's impressive. They're like, oh, they're glassy-eyed.
I have a daughter,
Okay.
though, that if she sleeps wrong,
Cool.
she gets a fever. The other one never does. So
Yeah.
it's odd, too. It's like...
So another important point about fevers in neonates, so we talked about bacterial infections and how that's always the first thing we suspect. There is a particular viral infection that can be deadly in neonates that the regular population doesn't think of that often as being bad. So herpes, HSV. The common ones, both oral and genital herpes, can infect the neonate, and those can be causes of encephalitis, or you can get disseminated herpes throughout your bloodstream. And that's one that can actually cause a younger baby to truly spike a fever. And one that if we have a baby who spiked a fever, we will test in the CSF and treat with acyclovir. So it's not just antibiotics in this case, it's often also acyclovir.
And antivirals, yeah.
Specifically for herpes.
What about vaccines in the newborn? What do they get? What do they need?
And what cultures don't get them.
And more importantly, what should we be asking of, let's say, a relatively recently born child, of the parents to make sure we're getting you good information or him good information when we're bringing him to you?
So in our population, most of the population who's coming into us from the outside is going to be less than 2 months.
Yep.
So the only vaccine they're going to have gotten at that point is going to be hepatitis B, which we give during the newborn hospitalization. The first kind of slew of vaccinations, if you will, comes at 2 months.
Okay.
And we do give it in the NICU, but it is one that most babies get at their pediatrician's office.
Sure. Hopefully baby. Hopefully they're well and they're out in the world, right? So.
Yeah, but it's always good to ask if babies are vaccinated. Most of the babies that you're bringing to us are just going to have had a hepatitis B vaccine,
Sure.
but after 2 months, you're looking at babies who've had
Tdap, MMR,
A Tdap.
rotavirus,
No,
not MMR yet.
MMR is a year. So a Tdap, and a Hib, so Haemophilus
Yeah.
influenza,
Rotavirus, right?
4 months and 6 months, I believe.
Okay.
We don't give rotavirus in the NICU, and it's because
I can't keep up on that.
I know, it's been so long since...
My dogs get rabies shots.
I just made an appointment for my dog to get a rabies shot.
They're getting Gardasil early now, too, though. Not that early.
Not
but
in the
maybe
newborn period.
It's early, though. I want to say it was like a year or something, though.
I thought it was approved down to 9.
Yeah, I was thinking.
Okay, maybe that's what it was. Again, it's been a long time since I was in the pediatric area, but it's...
I think the whole overall point is vaccines are good. Make sure you get a vaccination history. On your patient. And most parents don't know. You'll have 3 sets of parents. Either they, for their own personal beliefs or religious beliefs, don't vaccinate their children. They kind of vaccinate their children, so they'll do a delayed schedule. They don't feel comfortable getting their child to get all the vaccinations at once. And then you'll have parents that vaccinate their kids on schedule as always. So when you ask them, I just ask, is your child vaccinated? They'll say yes. You get all the other ones? Yes. That's all you have to ask. Like, are you on a regular schedule? And that's honestly probably the majority of people that they vaccinate their kids. They're getting them on a normal schedule. Yeah. They will likely often offer up that they're on a alternate schedule if you ask them, or they'll just say that we're not vaccinating for whatever religious reasons or their own personal reasons.
And I think around here, your biggest population is the Amish population.
Correct.
So we do run into a lot of sicker babies out that way, and RSV and things like that.
So when you're thinking 2 months, so when we're thinking after 2 months, the things that babies should have gotten, so you mentioned the Tdap. I mentioned Hib or Haemophilus influenza. We talked about hepatitis B. They also get polio, and they get Prevnar.
That's the one I was thinking of.
The one thing that I will say for the people that are conspiracy theorists, because this was recently in the news, there are people there for their personal beliefs that don't think that vaccines or work or they're dangerous. Understand that the United States just waged a information war on China against giving the COVID vaccine in hopes to essentially have COVID spread more. Did you see that story?
No.
Oh.
We look at very different websites.
We do. But I guess my point in that is that there are, if you're talking about, this is getting really deep into the whole personal beliefs about disinformation campaigns, that there are players out in the world that are actively out there trying to convince you not to get vaccinated because their gain is that they're hoping you don't get vaccinated for the bad outcomes that come from it.
Yeah.
Science says that vaccines are good. Yep. A lot of good comes from vaccines. Short of having your doctorate, I would trust the people that have risen to their accolades, whether it's in the CDC, NIH, that they're putting out the best recommendations for the populations, and that is vaccines are good.
Mm-hmm. And we vaccinated ourselves and our children.
Yes. To that point, I was one fighting to get my COVID vaccine as soon as I possibly can, because I was literally on the front line. I was one of the first people probably to intubate a COVID patient in the Akron area. I mean, and that was years before we had a COVID vaccine. And I know when the first ones came out, ER was on that short list.
I got my first one December 30th, 2020.
Oh, yeah. I'd have to look back at my card, but yeah, we're exposed to it, right? Mm-hmm. We were swimming in it. I was intubating patients and then taking showers at work.
Yeah.
We were part of the group of people that were showering at work, taking all our clothes off, and not bringing that home to our loved ones, and then slowly we kind of relaxed on it once we understood that virus a little bit better. But a lot of that was because just we're taking good precautions to protect ourselves and our loved ones, and understanding of how viruses and even bacteria can be transmitted. That we understand that even just basic hand washing goes a long way in stopping the spread of viruses and bacteria. Yep. So
that was a hard thing to kind of get to the general population. The recommendations for how to protect ourselves and how to protect other people were evolving with time.
Yeah.
And it wasn't that we were trying to give people misinformation, or we were trying to mislead people, or we were trying to scare people. We knew more over time.
Correct.
And we were able to do things that were evidence-based and smart, as opposed to things that were reactive. Yeah. To go back to the initial point really quick. So when you were talking about when you have a baby who has, and you ask them if they're vaccinated, say you have a parent who says no, or they don't do vaccines. A good question for them is, did the baby get vitamin K at delivery?
Okay.
Vitamin K, erythromycin and vitamin K are two things that are sort of getting lumped into the anti-vax movement. It's quite unfortunate. But vitamin K is given at delivery because babies are born vitamin K deficient. And we give it to them quickly so that they can build up their stores. And it's vitamin K, as you guys know, is really important in blood clotting. And so hemorrhagic disease of the newborn is the result of not having gotten vitamin K. So if you have a baby who looks bad, who probably hasn't had a fever, but if you have a baby who looks bad, who is unvaccinated, and you ask, and the baby has not gotten vitamin K, hemorrhagic disease on the newborn is high on your list.
Should be high on our differential. Okay.
Good to know.
No,
And I think,
Or at least on your differential.
on it, yeah. Okay.
and asking them where they deliver. Did you deliver in a hospital? Did you deliver at home? Was this with
Yeah.
a midwife at home in a swimming pool?
Yeah.
Or was this was a scheduled delivery with my OB that I've seen the whole time? Did you have prenatal care?
Yep.
Lack of prenatal care is probably it will send you down the being more prepared for a delivery that's not going to go as planned. With the understanding, I think we said this last time, like, we've been having kids for millions of years.
Eons. Yep.
The vast majority of them go very well,
fine.
but we all know that in EMS and emergency medicine, we're going to prepare for the worst and
Hope for the best.
hope for the best.
Yeah.
But be prepared that a patient who didn't have prenatal care is more likely going to have a more difficult delivery than a patient that had the prenatal care. Because if they had the prenatal care and they did all their screenings, they're going to be better suited for, am I a high-risk pregnancy? Am I going to be a high-risk delivery? Have I had high risks in the past? Or I don't even know I'm pregnant. I just started to get abdominal cramps, and I guess my stomach's a little bigger. And I haven't had a period in 9 months. That's really weird.
Yeah, it's weird.
This happens most frequently at that perimenopausal range, where people think they're gaining weight and having gastrointestinal
really?
issues and hasn't had a period, but they've kind of been on and off with their period anyway.
Right.
Ends up being an alien in the uterus.
That would be a surprise.
It doesn't happen terribly frequently, but it happens.
Interesting.
So you mentioned vitamin K and you mentioned erythromycin. So why that?
So that's eye ointment. So erythromycin eye ointment is to prophylax against chlamydia or chlamydia conjunctivitis.
And every baby gets it.
Yeah.
Yep.
Well,
Unless
their
unless the
parents
patient
refuse.
Yeah, unless they're
Which,
home birth.
I remember them asking during both our births, "Are you getting this?" We're like, "Yeah." Like, yeah.
Yes, please.
You're talking about babies, or there have been babies, and there have been people having babies for thousands of years, and they were unmedicated and unmedicalized for thousands of years. And during those thousands of years, women and babies died during childbirth.
Yeah.
And childbirth became something that we do in the hospital for the sake of saving women and infants.
Yep.
But when you look at today's population and people thinking that way, we're also the first generation that has a lower life expectancy than our parents.
Also true.
The population has gotten sicker over time so over time there have become different risks to childbirth than there were even thousands of years ago. There were always risks, but the risks now are different. I don't think that there were as many women dying of shoulder dystocia due to unregulated diabetes thousands of years ago as we have now. And so the risks are different. And
So you're saying we're still evolving, for good and bad. I mean, it's
right.
but it's true.
The population's always going great. We are always evolving.
But you could have the same fight, and I've heard it before about cancer. Let's say that back in the day there wasn't as much cancer. Well, we were evolving, and now we have different products and different things in the atmosphere, and that.
Yeah,
therefore, that is why it is also evolving.
Our environment is so different than it was before.
Yeah, absolutely.
There is a lot of comorbidities that now exist for as you get older. And a part of that is two things. It's how we've developed as a society.
Choices.
Yes. Personal choices. And
What you got in there?
Don't worry about it. Things my pancreas will yell at me later for.
Mountain Dew.
and medicines have given people a new lease on life, right?
Yeah.
If you had diabetes, and you had juvenile diabetes, type 1 diabetes, those patients didn't live to be childbearing ages,
right, yeah.
right? They didn't get to those points. If you even look back, even the 100 years, there's been a lot of work on the pregnant mom, like diagnosing gestational diabetes early and managing that from a standpoint that we didn't even do 100 years ago.
Yeah.
I mean, the person that we were talking earlier off camera, talking about the real true leaders in the neonatal phase and even the with pregnancies, those people that led a lot of charges and changes are still practicing in medicine these days. They work at our local hospitals that we work with every day. And just to think that that person who led the charge on neonatal care or the care of pregnancy and diagnosing gestational diabetes and how that affects the woman as well as the baby, they're still practicing doctors.
Yeah.
Like, it's a very recent developments in the medical history.
I mean, think about HIV. So we started to know,
A perfect example. Yeah.
we started to know about HIV in the last 50 years, certainly, but maybe even more like in the last 40.
40. Let's say 40.
And HIV has gone from being a pretty quick death sentence to being a chronic disease.
Yes.
A very manageable chronic disease.
Yeah.
Well, geez, I mean, on an acute, look at COVID. I mean, we were all under the impression in the EMS world it was a death sentence if you got it, at first. And the first wave of it certainly took out some of the immunosuppressed and people with comorbidities, and we saw that, and it was scary, but we rapidly overcame a lot of those fears.
Well, and COVID did what viruses do. So what a virus's goal, any pathogen's goal really, but a virus's goal is to reproduce. And you're not going to be able to reproduce if you kill your host.
Yeah.
And so COVID evolved and evolved and evolved from a disease that was killing its hosts pretty regularly to now a disease that makes you kind of miserable.
Yeah. Makes you sick.
Makes you miserable in a way that you spread it everywhere. So you're coughing and sneezing and getting it to other people so that it can reproduce and spread itself. But it's not, for the most part, killing its host anymore.
Yeah.
The two kinds of babies that we worry the most about are going to be your inconsolable baby and your lethargic baby. So the one that you can't wake up and the one that you can't make stop crying. And those are two babies that you should always bring to medical attention. Be it your pediatrician, or honestly, you shouldn't bring your lethargic baby to your pediatrician. That should go directly to the ER.
Yeah, right.
But that happens so often.
But if we're seeing them, we should be in a position to be like, no, this is not safe for your pediatrician.
This is not safe. This is not normal.
Yeah.
This baby needs to come with us. But your inconsolable baby can sometimes be just as sick. And so those are babies that will certainly get looked up and down, looking for reasons for discomfort. Yep. And some of them can be the same. So your septic baby can be, your septic baby can be lethargic. Your very sick baby can also be inconsolable.
Inconsolable, yeah.
One kind of pearl in pediatrics and in baby care is something people don't think of, but can make babies very uncomfortable, and that's hair tourniquets.
I have a note right there.
Yep.
It's immediately under inconsolable baby. So.
Yep. I actually thought that's where you were going with that.
Well, yeah, wherever it needed to take us.
Yeah, so babies can get hair tourniquets, and they can be super subtle. So hair can shed from our heads, certainly long ones, but they don't have to be as long as mine. And they can wrap around little baby appendages. So little baby fingers, little baby toes, little baby penises.
Yep.
Can all get hair tourniquets. And those are things to bring to the ER too, even if you find them at home. And the reason for that is it can get very swollen distal to the point of the constriction. And you may have gotten some of it off, but not all of it off. And so you want to bring them in and just make sure that all of that hair is gone.
Yeah, and to your point, like, I didn't believe that. Like, I didn't know that until the first time I had seen that working in the ED. Mm-hmm. And it was just amazing to me how small that hair, because it's a hair.
It's a hair.
And the parents thought they got it off, and it was a day later, and it was still bad, so they brought it, and sure enough, the doctor was like, no, there's still a hair on there. So it's amazing. And the fact that it doesn't have to be that long, like you said, but it works its way perfectly around there. And
yep. They're so thin, and they can wrap so tight, and they can really compromise your blood supply to those little appendages.
Back to inconsolable, unarousable babies. Those are what we talked about before, like door exams, that that's a sick baby, that you should intervene and say, we need to go to the ER. I'm definitely one to try to avoid the ER as much as possible. Yeah. I have enough work to do. I don't need more. Sure. But those are the patients we're all happy to see. So bring them in. I'll be happy to do a once over. And
I think from the EMS mindset, the unarousable baby is a no-brainer, right?
Sure.
That's the one. Okay, let's go.
Yep.
We're scooping them up. Give me the story on the way out to the truck, right?
Yeah.
But it may be that inconsolable baby. There might be some bias there. Be like, oh, this kid's just crying. I've been in the room for 35 seconds, right?
Sure.
They're explaining to me, this kid has not stopped crying for X amount of time, it's easy to, supplant what,
and it can be something so simple. I mean, we had my second wouldn't stop crying for 4 or 5 days. And it was progressively getting worse, and we took her to the pediatrician. They tested her stool, and she had an issue with lactose. So they switched to a formula, and it fixed it. Yeah. So, I mean, but it could be something that small, but...
And it's hard. Babies cry a lot.
Yeah.
And there are some babies who cry more than others. Babies cry a lot. And there are babies... There are some babies who just have witching hours, who are...
Hold on. That's a clinical term, right?
I know exactly what you're talking about.
Who are inconsolable for hours at a time every day. You'll have some babies who just... I mean, legend has it, and I'm sure my parents will watch this, but legend has it that I was a baby who cried inconsolably every day from 6 p.m. to 12:15 a.m. And I'm sure was a joy. But, and sometimes if you are called because you have an inconsolable baby, it may wind up being truly nothing, but you're taking that baby and bringing it to the ER and having somebody do a look over can mean everything to that, right. Can mean everything to that exhausted family or frustrated family or, anxious family. Just telling them your baby is okay can go a really long way. So you do the once over, you make sure that this baby truly is okay, and sometimes they're not.
Right.
Look for hair tourniquets. Look for all the things, but look for hair tourniquets. And if they are okay, reassurance goes a long way in pediatrics.
And I think that if you are a parent and you have that experience, it goes a long way. If you're holding a baby and baby's calm and you're a problem, it's like, yeah, my baby did this too at 2 months or whatever it is, or I've been through this with my kid, or now they're fine. Take a sleep. We'll hold baby for a little bit in the ER.
And you bring up a good point. Babies feed off nervous energy. Yeah. And so if the baby has been crying, which has gotten the family upset and frustrated and anxious, the baby is going to feel that anxiety and is going to be anxious itself and it's going to cry more. And so it may initially frustrate the family that you've picked up the baby and you're holding it. Now the baby is happy. But it does give them a respite for just a few minutes. It gives them time to calm down, which gives them time for that nervous energy not to come off of them.
And I get to ask these questions, like, what other questions do you have? Like, what was your big concern? Baby looks great to me, acting appropriate, is pink in all the right places, is moving all its extremities, real playful with me, or acting as they should be, like, outside of your realm. But when we get to stranger danger, that's an appropriate thing that I walk in the room, they hide behind mom or dad. I'm like, great, that's totally normal. Yeah. Oh, they just started doing this. I'm like, good. They're right on there. They're meeting their milestones. Exactly what they want them to do. Yeah. You want a popsicle? Popsicle?
It's reassuring. I mean, even my wife was an only child growing up. I had lots of brothers and sisters, so I got exposed early on to pediatrics. But just telling them that it's not broken, like, you didn't break it, it's fine, it's going to be okay, I think really goes a long way. But yeah,
babies are resilient.
Yeah, my poor 4-year-old. She'll be 5 next month. But no, she fell when she was 2. I just got home. I just cut the grass. I don't remember if I told the story or not. But I sat down and I cracked a beer, and I didn't even get a drink yet. She had a plastic screwdriver, and I just went, crap, and I set it down. I said, Cassie, I'm going to the hospital with Lily, and I grabbed her head, and she's like, why, I'm like, don't worry about it. But I didn't even look. I was like, I know this is bad. So we went to the hospital, and they sutured her, and you can still see it, obviously. Sure. But anytime that poor girl falls now, the first thing she does is it okay? Am I okay? She thinks she's going to be disfigured, and it's like, even though she was 2, like, that stuck with her, and that really stuck with me, because it's like, she is a little person, and like, she does care, and she's scared to death that she's going to be disfigured, and it's like, wow. I don't know. To me, that was very homing. It's like, man. So every time she falls now, she's like, am I okay? Am I okay? Is my face okay? It's like, oh.
So when we were talking lethargic or talking inconsolable, another one to put, I think, in the category of things to be evaluated is your baby who previously ate well who now doesn't. Or your baby who previously ate well who is now turning a little blue around the mouth when they feed, sweating with feeds, or things like that. Those are also ones to take very seriously. So the turning blue around the mouth when you feed or the sweating when you feed are signs of ductal-dependent heart lesions or congenital heart disease. And babies who previously ate well, who are now, 2, 3, 4 days old and are not eating well or are turning a little blue around the mouth when they feed or sweating when they feed, those are ones to worry about their hearts. It can be heart lesions. It can also be arrhythmias. So tachyarrhythmias can cause babies not to eat well. Those are interesting ones. So if a parent tells you that their baby ate well until, 3 hours ago, their last feed, so 3 hours ago they ate well, and now this feed, they just won't. And then the next feed, they just won't. But, the feed before that, so they know exactly the point where they last fed well.
Right.
At that point, you can sort of tell when that tachyarrhythmia started. So you pick up that baby, and that baby has a heart rate of 250 or whatever. You can sort of tell when that tachyarrhythmia started. If they can't give you a history like that, so the baby was doing well and over a period of days started to not feed quite as well, that's one where you don't know where it started. And the differentiation there is important too, because the longer a baby has a tachyarrhythmia, the more important it is, or the less stroke volume and the less cardiac
output. Sure.
Output. What I'm trying to say is their cardiac output is at that point dependent on their rate. And they're starting at that point to go into failure. And so those are babies that if you shock them or correct that arrhythmia, give them meds to correct that arrhythmia, whatever you do, those are babies that if you correct that arrhythmia, they will suddenly lose their cardiac output and they will be very sick very quickly, like ECMO sick very quickly.
Wow.
So that's more of an ER thing, I think, than it is an EMS thing. But
I mean, that bit of history that knowledge, in the field, that may make a big difference on whether we...
If you have a kid who is not eating great but otherwise looks good, they're pink, they're well perfused, they have a tachyarrhythmia, you're better off just bringing them to the hospital. Get them there quickly.
Well, I think that has to be said with neonates and peds. They have infinite ways to compensate until they don't. We say this clinically. They'll go off that edge because they can compensate up until that edge, and then they no longer compensate. So maybe slower to intervene if they're pinked, well perfused, and going, okay, get them to the hospital to have us evaluate them, because it could be pyloric stenosis, and they're just tacky because they're not taking anything in, or it's a tachy dysrhythmia that needs to be taken to see her.